Thank you, Jairaj. It's always pleasure to meet your MBBS colleagues, and that too on sharing a stage with them is always fun. I will thank Prashant and the team for organizing such a wonderful event. And I will also thank my dear friend Ashish for setting the tone right so that I can take things ahead from here. After the basic introduction of immunotherapy, what I'm going to talk about in the next 15-20 minutes is about, the side effects and how we should take it ahead, how we should, investigate, look for certain specific pearls of wisdom. So we'll try to cover certain practical points, actually, what Prashant mentioned. So we are in the era of immune checkpoint inhibitors. Actually, I will say that we are in mid of a storm, because every month you will see there are a couple of immunotherapy drugs which have been licensed, approved, never seen such kind of a, from lab to clinic approval of drugs in any branch. You just name, and these drugs are costly like hell. They all on average 2 lakh per vial, and you are getting approval left and right. So a lot of things are happening. Maybe it's a bubble to some extent, but it is also useful in certain tumors. But yes, we are in midst of a big storm. I mean, there was something in the newspaper, and we were flooded with messages about an immunodrug used in US with 100% cure rate. So it was prematurely put in newspaper with a different intent, and it went out of hand actually. So a lot of hype is created around this group of drugs. However, this concept is not new. This concept is very old. In 1800, when the scientists realized that there is tumor infiltration by lymphocytes and all, possibly they do better than the others. It was as simple as that, which eventually led to crushing the tissue. And we have done in our labs also during training days and producing some crude vaccines. And they worked in some patients like melanoma and all, which are immunoresponsive diseases. And then the whole gamut started from there. First established therapy was interleukin-2. Which was used in various diseases, many in even CML, and of course we have various interferons used in hepatocellular diseases. Then the real era came actually after that. Once we knew that interleukin is there, we started with some cancer vaccines, brain vaccines. We were trying to use so many cancer vaccines. All was a failure, utter failure, except few Chinese vaccines for head and neck cancer, which actually were successful. So possibly we were missing that. We never understood what immunotherapy is, honestly. So we were just trying to hit in the dark, and we were getting some results sometimes no. And this was because we didn't realize that every tumor is different, and every tumor will respond to immunodrugs based on the antigenic exposure or antigenic load. Like what Ashish mentioned, that in the squamous cell carcinomas, the smokers respond better to immunotherapy than non-smokers, because smoking causes more antigenic exposure in the blood cells because of smoking. A lot of damage occurs, and this causes more antigenic reaction to a particular thing, and they are more antigenic hot tumors as compared to a non-smoker. So they have more response rates. So from here we moved to first drug, which was anti-CTLA-4. It's used in a lot of rheumatological disorders also. And then this era of PD-L1. Once we understood the on-off mechanism of tumor surveillance, there's something called as immune surveillance. Everyone sitting in this room, actually every single minute we have a chance of getting cancer, but we are not getting it because just before your division, the critical cell cycle division, there are checkpoints. They check the cell whether it is right or wrong. If the cell is wrong, your checkpoints don't allow the cell to divide and go into the mitosis phase. So abnormal cells don't multiply, because once they cross that phase, then there is no looking back. They will multiply exponentially, 2, 4, 6, 8, and then they'll become a tumor eventually. So this checkpoint inhibition and this discovery, which gave a Nobel Prize to the Japanese scientists a few years back, and after this paved the way for real understanding of immunotherapy, what we are talking today. And these are the group of drugs which we have: anti-PD-1, PD-L1. All these are basically acting on the tumor cells or in the T lymphocytes which are there. And yes, of course, there are newer drugs which are in pipeline. We can't discuss. What we are going to discuss is that one, what Ashish mentioned was about immunotherapy in lung cancers, but the immunotherapy is not related or limited only to lung cancer. If you see this cartoon, it is probably, highly effective in melanoma, I feel. Hodgkin's lymphoma, mediastinal B-cell lymphomas, head and neck cancers we are using, urinary bladder cancers we are using, renal cell carcinomas we are using. And if nothing works, then pharma drives the market. So they have said, do a test called as MSI. If MSI is high, you can use across board all solid tumors. In that trial, only 2 patients of prostate cancer were there. But in clinical practice, based on that one thing, we are using that in prostate cancer also. So that strong is the data, which means that, yeah, it's there. So there's a lot of hype and bubble created. You have to choose your patients appropriately and the disease appropriately for these costly drugs. Because not only they're costly, they can produce certain side effects on which I'm going to talk about. So are these drugs really so impressive blockbuster, or it's an hype or bubble? So they are actually in certain diseases. If you see this chart, this is melanoma trial overall survival. On the left side, you can see from 1975 to 2005, there was no immunotherapy. We are just struggling. Crude vaccines, injecting here, there, all was going on. Survival was dismal. And then this era of immunotherapy came, 2017. You see the graph, survival is 95%. Pediatric ALL don't have that. You're talking about a disease called as melanoma, when no one is to survive. So that is the impact. But of course, this is a selected subgroup of patients who kept on responding and received immunotherapy for 2 years. So you select out a special group in this, but this special group is doing better than a pediatric leukemia. So this kind of a survival was unheard. So this is definitely an impact. I mean, it is nothing less than a magic to me. From baseline to going to 95, 96% is unbelievable. But again, same caution that you have to be clear that what kind of patient you're choosing and what kind of a disease you're choosing. The marker which Ashish meant, PD-L1, is the current guideline for using certain drugs. Like in lung, approval is based on PD-L1 monotherapy if it is more than 50%. But the same is not required for head and neck cancer or bladder cancer. So the world is not unanimous or not uniform about which is the optimal marker or biomarker based on which you can give immunotherapy to a patient. So that end is very loose today. With purpose, without purpose, I don't know, but it can be used to a very large spectrum of patients today. It is working in some and not working in many. So immune-related adverse events, as the responses increases, the chance of side effects increases. And how do they cause side effects? They are very unique drugs. So they are not the routine chemotherapy where blindly it will go and kill the DNA of the abnormal cells, also normal cells. Hence, rapidly dividing cells like oral mucosa, hair, and all those things, blood counts goes down in chemotherapy. Immunotherapy, they act through immune system. They act as an inhibitor of the inhibitor. So they actually act as an autoimmunity. So on autoimmune mechanisms, they can cause anything in the body, practically. All ITs can be caused by this group of drugs. So this is the chart which you have to focus that right from head to toe, anything can be caused by this special subgroup of drugs, encephalitis, septic meningitis, hypophysitis. Now this hypophysitis is very difficult to pick up because it is so subtle. You have to be very, very sharp and high, index of suspicion to pick up a hypophysitis. Uveitis, orbital inflammation, pneumonitis, which is a concern and where the audience today is interested. We'll talk a little bit more about pneumonitis today, but it's not only restricted to pneumonitis. These drugs can cause anything possible. Enterocolitis is very dangerous. Patients on chemotherapy, we give these immunodrugs, they come with loose motions. Sometimes they don't report to us. They say that, oh, loose motions, kuch bahar khaya tha. Yeah, I know chemo mein, immuno mein hota hai. But this is immuno. This is not chemo. This is not infective. And patient presenting just 1 day or 2 days late are practically dead because this is a vicious cycle. It's an exponential, damage which occurs. So if they report early, these all are salvageable situations. If you report late, a few will die. However, all said and done, these drugs are still better than your chemotherapy routine. And these are the meta-analysis where they've tried to see any grade adverse events. So definitely your immunotherapy was scoring much better than chemotherapy. So safer way of treating cancer patients. Fewer total adverse events, 67 versus 82. Fewer higher grade adverse events are also less. Less treatment discontinuation with immunotherapy as compared to chemo, and less death treatment related. So coming to the commonest side effect which we see, diarrhea, colitis, pneumonitis, dermatitis, and hypophysitis. In our dark skin patients, dermatitis possibly we miss in clinical practice. We ourselves are not so vigilant in picking it up, but it is still very common. Diarrhea, if you see in this chart, if you are using more than the right hand of the chart, if you're using more than 2 drugs, which you are using for certain tumors, melanomas, RCCs, the incidence of diarrhea dramatically jumps up. So it says that, using 2 immunodrugs can give you better responses, but can give you more side effects also. And there is something peculiar about this group of drugs, the onset of grade 3, grade 4 toxicities. So you should understand that they have very uniform pattern actually and very predicted pattern of getting side effects. So if you see the skin toxicity, it occurs in the first 3 weeks. Earliest to occur is skin toxicity. Then comes the GI toxicity, colitis and all, which occurs in say second month. Hepatic occurs in 8 to 9 weeks. Endocrine in 11 to 12 weeks. Pulmonary, which we are interested here today, is in roughly 2 to 3 months. But again, a point to be noted here is that pulmonary toxicity and the occurrence, the time period when they occur, also depends upon which tumor we are treating with the immunotherapy. Like the same pulmonary toxicity, if you see the meta-analysis of all the patients who are melanomas, where we're using these drugs more common, they get pulmonary toxicity in 5th month. While all other diseases, they will get in the 1st, 2nd, 3rd or month, maximum 3rd month. So you have to also know which disease you're treating and when to anticipate what's happening to the patient. Renal care is rare, but occurs in around say 4th month. So this is what happens when you're trying to increase the number of agents or number of weapons fighting. You can also end up getting more side effects. Same is true for immunodrugs. If you give a combination of nivolumab with ipilimumab, one is a CTLA4, another is a PD-1. You can see that out of the 13 patients, 59 had grade 3 grade side effects in the doublet arm when you're giving 2 immunodrugs, as compared to Nivo or IP, which was just 28 and 23. What are the general guidelines for management of these immune-related adverse events? It depends upon the grade. So grade 1 is asymptomatic or mild symptomatic. You may have some chest findings in the CT. Observation, supportive care, continue with the ICI therapy. Grade 2 is moderate symptoms. Grade 3 is, grade 2 again, till it resolves by low dose steroid. Till grade 1, you can possibly re-challenge with your immunodrugs. But grade 3, grade 4, once it occurs, possibly you just pull the patient out somehow, don't re-challenge them with the immunotherapy. I will come to that in details. The best part is that most of these immune-related adverse events are actually reversible by immunosuppression, steroids, whichever we are using. The skin, which is on the top panel, the yellow one, it takes some more time actually because it's very nagging side effect, but eventually it also responds and get controlled with use of steroids. Few word of caution for the guidelines for using steroid. Because these are grade 3, grade 4 reactions where you use steroid, you require to give them for a longer time and have a very slow taper. Moment you try to do rapid taper, the symptoms will recur back. The toxicity will recur back. So if you're going to give steroid for a longer duration of time, you will get the problems of steroid long-term use. So monitoring blood glucose, adrenal insufficiency, muscle weakness, you have to be very sharp to pick this up. Prevention, gastritis, all antacids, opportunistic infection, PCP or PZP, prophylaxis, osteoporosis, all those things you have to be on it all the time if you're using a steroid. This is very interesting slide. So because steroid work in a mechanism which is opposite to this drug, steroid are immunosuppressants, and you are giving immunotherapy actually to inhibit the inhibitor so that your immune system becomes robust and the immune system goes and kills the tumor. So steroid technically is counteracting the effect of immune drugs. So this was the great worry for every one of us that if you're going to give, in fact, it was a contraindication initially when these drugs were introduced some 8-10 years back. If you're on steroid, you can't give immunotherapy because the effect will not be there. You're giving 2 opposite drugs and such a costly therapy. If it is here 2 lakhs, it is 20 lakhs in US. So if such costly drugs are given, is it worth giving? So a lot of data eventually got generated. We realized that it is not so bad. If you are giving steroid at a dose less than 10 milligram or equivalent 10 milligram of prednisolone, you can safely give this drug. It doesn't impact the outcome of this treatment responses of this group of drugs. This analysis shows that in the left side, if you see baseline steroid early and no steroid. Naturally, no steroid is possibly going to do shade better than others. But if you see the early steroid and baseline steroid is for those who require steroid for other reasons, rheumatic disorders, other disorders, or tumor-related brain edema or some other reason for which steroid has been started. So this was the observation, general observation. On the right side panel is very interesting. What they saw is that if you analyze the same data by reason why steroid was used, and in that everything changes. If you are using an early steroid, it is as good as no steroid if it is used for non-cancerous reason. But if you're using steroid for a cancerous reason in first 8 weeks, which is possibly we are selecting out a bad disease biology. It has nothing to do with the immunotherapy drug. Your disease is bad. So that is the impact of it. Otherwise, it doesn't impact at all. So if suppose you're going a little bit higher steroid, it's okay. These drugs are an important tool for someone. So give it. This is a suggested decision tree, simplified way of looking at things. If you find some symptoms which can suggest that HRCT is the best modality, based on what you find there is a tree to rule out so many things and then come to the arrival. Many times, this getting a diagnosis of drug-induced pneumonitis or ILD by immune drugs is not easy. It's a diagnosis of exclusion. You have to first rule out infections and so many other things before you arrive at the diagnosis. We don't end up every time doing BAL. Sometimes on clinical suspicion, we start steroids, which is at times not so easy a decision in these sick patients who have other corroborated findings in the lung because of the primary tumor itself. Your tumor can grow. So this can be actually tumor progression rather than your drug causing anything, or lymphangitic spread of the tumor. Or this one rare phenomena called as tumor hyperprogression. So hyperprogression or pseudoprogression. These two things are so difficult to differentiate in clinical practice, and that too with this background, it requires some multidisciplinary approach. The pulmonologist, the infection, ID, everyone sitting together to make a discussion. Pseudoprogression is patient is improving, scan is worsening. And that is because initial phase, all the T lymphocytes come to the tumor cell site to kill it. So the lesion appears larger, but after some time it disappears. So that is pseudoprogression, false progression. Hyperprogression is actually true progression. You start the immunotherapy, it just rapidly goes out of control. Why does that happen? No one knows. Still a lot of speculation going on. Possibly it is again the disease biology which we have missed up. Because for hyperprogression, you should have a scan 3-4 months before also, which we don't have in many cases. So these are the differentials, these are the issues where we struggle to really give a clear diagnosis. But sometimes on empiric, you can start therapy because patients are sick. They're going to become sick faster if you don't act on it. You can't sit on 2 to 3 days for these patients to decide what to do. What we do, we give steroid, methylprednisolone at the standard dose 1 to 2 milligram. If they're refractory, then of course we have options of infliximab, mycophenolate, or endoxon, or sometimes IVIG. Rarely I have used one patient, and most of them they respond well to steroids. So very easily manageable if picked up early. So inter-team consultation or communication is the key to treating this group of side effects. These are some wonderful pictures. An organizing pneumonia, hypersensitive pneumonitis, just holding the steroid, holding the drug and treating with steroid, wonderful responses seen in most of the cases. These are some rare things like a diaphragmatic myositis, or sometimes they may mimic a pulmonary sarcoid. So they will have a lot of interstitial pattern, and then there will be nodules in between. So we should give a picture of possibly treating with like a sarcoid. So you have to be very clear about the differential of this. Two important piece of information again for this group of drugs is that these immune reactions can occur after discontinuation of the immunodrugs. So this we should understand that, on average, more than 16 weeks, it can range up to 33 weeks of stopping these drugs. You can get this drug-induced ILDs. So if someone has said that I stopped, say 4 months back, yeah, it can happen. Maybe we keep that as the differential there. Maybe lower in the list, but it will be there. So we should not forget as a pulmonologist that these drugs can cause delayed IREs, and we don't usually re-challenge in most of the cases if it is grade 3, grade 4. This is another important impressive data. Autoimmunity as a prognostic marker. As a pulmonologist, this era of TKIs came, we were excited, and it really changed the way we are treating lung cancer today, the mutation positive. A lot of rash, diarrhea is to come. Then the data came of rash versus survival. Those who have intense rash with erlotinib, gefitinib, they have a longer survival, and there is enough data for that. So same was corroborated here based on your immune reaction. So autoimmunity as a prognostic marker, you can see clearly the overall survival was better if you develop an immune-related reaction versus not. Doesn't matter whether you're using steroid or not. Getting that is important. So it is an independent prognostic marker in patients who are treated. I will conclude with few points here. More patients are being treated with immunodrugs as indications have expanded to newer malignancies and earlier lines. All this started in metastatic. Now we have immunotherapy drugs in adjuvant. And the classical example for you all is lung cancer. Lung cancer after stage 3 CTRT, we give durvalumab for maintenance. Okay, we are giving it for a 1-year maintenance. And this has really changed the outcome of patients. What we have to understand, or the audience here, is that these patients who have got radiation first, and now you are giving immunotherapy drugs, there is a radiation-induced lung injury in that anatomical portion, but it's very difficult sometimes to have an anatomical portion. It's very difficult. A lot of overlap is there. So you should keep in mind these two things and patient on durvalumab. So you will get more probability of getting a drug-induced ILD in patients who are post-RT or post-high dose chemotherapy treated. Smokers who are current smokers will have a higher chance of developing ILD because of these diseases, because of these drugs. Immunodrugs can cause ILD by activating the immune system, and more commonly they present in the emergency department as diarrhea, colitis, dermatitis, pneumonitis, and hypophysitis. When a patient with cancer history presents to the clinic, ask them about the immunotherapy treatment and the autoimmune conditions that they're having. Consult promptly with specialist, which means a MDT kind of a thing. Manage based on the severity of symptoms by providing supportive care, discontinuing the therapy or holding it for some time using steroid or other immunosuppressants appropriate. You can always make use of these online portals which help you in guiding the severity, how to go about and all. I will thank you all for patient hearing. Any questions?
So we'll proceed on with the third talk and have a question session for all three of you all together. Yeah.
Good afternoon. I would like